So after introductions, I will briefly cover the status of the consortium right now, so you have the latest update. We're going to be walking through, as you can see through this agenda, the basics of benefit plan design and how it's constructed. And then we'll talk about the regulatory framework and environment that we work within for benefit plan design. At that point in time, we're going to take a 5-minute break, which will give you a chance, if it's 10 o'clock or after 10 o'clock, to then feed your meter. So you can actually stay for the rest of the retreat. And also you can grab some more food and you should feel free to get up as you need to while we're working here today.
Because it's good for you.
And it's good for you. It's good, healthy food. So thank you for noticing that. After the break, then we'll come back and we'll talk about our role in developing and writing benefit plans. So that's really the guts of what we're here for today. And then we'll talk about what happens with the benefit plan once we're done with it. And then finally go into the new and evolving benefit options that are available, specifically wellness. So today's presenters are myself, Don Barber. I'm the Executive Director for the Health Consortium, and Steve Losey to my right and your left, our benefit plan consultant from Losey and Cahill. And then to his right and my double left is Beth Miller from Excelis. And on my other side is Ashley Masucci from ProAct, and all three will be presenting. Before we get into introducing ourselves, I just want to acknowledge Michelle Potteroff for her unwavering support and energy to keep this consortium operating. She's such a key player. And also Jim Blizzard, who's running around here trying to keep our microphones working and making a video recording of this event as well. So we can have that. What I'd like to have us do, so we all know who's in the room, is just go around and say our name, affiliation, what we have, and then any role that we might have specifically with the consortium. And an only way for this to be recorded is for you to speak into the mic. However, for those that are sitting not near mics on the side, we'll just, at this point in time, we'll allow you just to speak as loudly as you can. But for future comments, you'll need to come up to a microphone so we can record you, and I thank you for that indulgence. So having said all that, I'll start out. As I mentioned, I'm Don Barber. I'm the Executive Director for the consortium, and I'm also the supervisor from the town of Caroline, and we'll go to Ashley next.
I am Ashley Masucci. I am the ProAct account manager for the consortium's prescription drug plan, and I have worked in the benefits administration industry for over 6 years.
Chuck Rankin from the Village of Groton, Clerk, Treasurer, and Administrator. Fortunately for you, I won't be presenting today. I am the delegate from the Village of Groton to the Director from the Village of Groton for the consortium, and I'm also Secretary of the consortium.
I'm Betty Conger. I'm a village trustee from the Village of Groton, and I'm also a member of the Joint Strategic Planning Committee.
And I'm Kathy Miller. I'm the supervisor of the town of Lansing, a commissioner on the consortium. I'm on the finance committee for the consortium and was on the MCA committee.
Mary Ann Sumner, supervisor, town of Dryden. I'm a founding member of the board of directors, and I'm on the grievance committee, I think it is. And I'm proud to say that I see at least 3 of my department heads in the audience as well. Yay, Dryden.
Hi, Mike Murphy, Dryden Village. I'm on the planning committee and also on the director committee for our
Jim Bauer, Bolton Point Water System, UAW, Local 2300 Steward.
Steve Thayer, City Controller for the City of Ithaca, also CFO for the consortium and Chair of the Audit and Finance Committee, and also on the board.
John Munson, Town of Ithaca.
Joe Slater, Town of Ithaca, Public Works Department, representing the Teamsters Local 317.
Judy Drake from Town of Ithaca, Human Resources, and I'm the current chair of the consortium.
Debbie Kelly, Town of Ithaca.
Matt Cook, City Manager, City of Cortland. I'm on the Finance Committee. I chair the Wellness Committee, and that's enough.
I'm Jackie Kippola. I work at Tompkins County Administration, and I go way back with this consortium because our office wrote the grant to get this consortium up and running.
And I'm Nancy Zahler from the town of Ulysses, and since they're not by the mic, I'm here with our town clerk, Carissa Parlato, and Michelle Wright, our deputy supervisor.
Great, thanks. I'm Beth Miller with Excelis Blue Cross Blue Shield, and have been with the account for over 20 years, and work closely with the city and county also. Thanks.
I'm Steve Losey from Losey & Kale. We're the consulting firm that works with the consortium.
So John Frazier, as loud as you can. Oh, you're going to go down mic, great. Turn it on.
All right, I'm very loud naturally, so this will work fine. I'm John Frazier from the town of Carolina, board member. I'm a board member of this consortium and chair of the MCA committee.
Thank you. Okay, Tim.
And
So thank you all. Michelle's been running around with copies of the PowerPoint. If anyone still needs one, just raise your hand so she can make sure you have a copy. Looks like she's done well. Moving right along then. This is a little background about the Health Consortium. We are actually an insurance company with all the trappings that an insurance company has. We collect premiums, we pay claims, we create and manage reserves to protect our members, and we write benefit plans. The Greater Tompkins County Municipal Health Insurance Consortium is a certified Article 47 health insurance company. And New York State law allows employers with greater than 50 employees to pool their risks together and become self-insured. But if you have if you're an employer with fewer than 50, then you only have one option, and that is to purchase community-rated product through the private sector until Article 47 came around. And even though Article 47 was started in 1993, we are the first Article 47 to get started since that time. And we do provide opportunities for the smaller employers, and a number of those are right here in this room, to be part of a consortium. Whenever you start a consortium, there are several things we need to do. One is the municipal cooperative agreement, and you've heard a couple people mention that around the table already today, which balances the interests of the larger employers with the small employers to create a successful health insurance company. We also have to fund reserves. There are 2 reserves that are required by state law, as well as the consortium establishes additional reserves so that it can protect its members and their investment that they have with the consortium. And finally, Article 47 requires a role for labor, and the consortium has found 2. They are the members of the Joint Committee on Benefit Plan Design and Structure. Actually, every bargaining unit has a seat on that committee, and there are 3 directors on the board of directors from labor. And finally, the Department of Financial Services is our regulatory agency. We report to them, and they have oversight over the operations of the consortium. And finally, we're very proud of the fact that we received our certificate of authority on October 1 of 2010, and we began operations on 1/1/2011. This is a list of our municipal partners, and since we met last year with our opening retreat, we've had 2 new members, which are the Village of Homer and the Town of Willett. This slide just shows that the number of covered lives and the number of contracts we've had over time since we've started. And this is important to note that the larger number that we have, the easier it is to run a stable reserving and a claims prediction, which we'll see in a couple of slides from now. This is the description of our income distribution. And you can see that roughly 99% of the income for the consortium comes from premiums, with only a small amount coming from other sources. And this is just a year-by-year description of what we saw in comparison to the original slide. But again, it's been running around 99% for each year. This is a slide showing the expense distribution. And for this slide, you'll see that 92% of the expenses are to pay claims. This is a very efficient model. Most of the industry is trying to make to 85%, and we're at 93%. And in recent years, we've been as high as 93%, and this year we're at 92%. So you can also see a few other expenses, but this is a very efficient and lean operation. Again, this slide just shows changes over time for other years other than just 2014. And this is a slide that I want to refer to, that having a large risk pool allows you to predict your claims. So the blue line is the budgeted and predicted claims for each year, and the red line is the actual. And if the red line is on or below the blue line, then we are receiving enough premiums to pay our claims. And as you can see, that has been the case for every month as we've gone through this. And it speaks well to having a large risk pool and the expertise of Losi and Cahill to help us set and predict our claims for the upcoming year. This is, again, is just a year-to-year, and shows the relationship between the different claims, budgeted and actual, for medical and pharmaceutical. And finally, this is the segue to the rest of the presentation. Health insurance in healthcare is paid for by a 3-legged stool. So there's the patient, who pays part of it and is very involved with actually starting the claim. There's the medical provider, which treats the claim. There's the insurance company, which is paying for the claim, and all these are tied together by one contract, which is the benefit plan. And now I will turn the mic over to Steve Losi, who will begin to talk about benefit plans.
Thanks, Don. We're going to go through and talk a bit about the different types of insurance risk models that are out there. Then we're going to get into some discussion about benefit plans in general, talk a little bit about federal and state mandates, and then we'll take a quick break and then get back into some additional conversation about the benefit plan itself, provider networks, how you use the plan, et cetera. But before we start talking about the actual benefit plan itself, it's good to have an understanding of the different types of insurance or risk models that are available in New York State that govern health insurance plans. If you look at the first exhibit, you'll see that for fully insured programs, and this is anybody that goes to the general marketplace to buy health insurance, kind of off the shelf, if you will, there's really 3 types of programs that you can purchase. You can go to a commercial insurance carrier, which is referred to as an Article 32 insurance carrier in New York State insurance law. And those are like the Aetnas or the Cignas of the world. Private, for-profit insurance companies typically have investors and the boards of directors and other investors that they have to make sure that they satisfy with their insurance products. Then we have what we refer to as not-for-profit insurance companies. These are under Article 43 of the New York State insurance law. And the primary examples of those are Excellus Blue Cross Blue Shield here locally, in central New York, and also Emblem Health, which is formerly GHI. Those are probably the 2 predominant Article 43 carriers you see in this area. Also Health Now, which is out of Buffalo. I know they've had some segue into this area over the years, but those are not-for-profit insurance companies. And then you have your HMOs. HMOs are actually under a different section of law. They actually come in under public health law because when they were originally designed, the mechanism for the insurance was really that they were not only going to be the insurance company, but the deliverer of service. Today, it's kind of evolved into more of an insurance company role versus a direct provider of care, but it's still governed by Article 44 of the health law as opposed to the insurance law. Then you can get into some other types of risk models, and we're specifically going to talk about self-insured plans because that's what we are in terms of the Greater Tompkins County Municipal Health Insurance Consortium. There's basically 3 ways that you can self-insure as a municipal employer in New York State. The first is you could do it on your own. So you could be a single entity, and you could self-insure your health insurance program as a single entity. There's really no size requirements. There's no regulatory oversight. Other than the fact that from a size perspective, it's very difficult, obviously, to do if you're too small. You know, typically we see for self-insured plans, I've seen them lower than 500 contracts. We certainly wouldn't recommend it because it's just too volatile. You end up having to purchase stop-loss insurance at a very low rate and ends up being an insurance plan anyways. So not necessarily something that would be available to all the municipal employers that are in this particular group. Then we also have Article 47, which is what we are. It comes under the health insurance law. It governs municipal cooperative health benefit plans. And basically there's, and we'll go through some of the rules and regulations that are associated with Article 47, but that's how this particular consortium has been established and is governed. The other model is what they call an Article 44 Employee Welfare Fund. That's basically a trust. It's a joint labor management trust, so there's a board of trustees as opposed to consortium board of directors, a little bit different model. But there are some entities that run with that philosophy. In terms of where our employers came from, or our municipal partners came from, before the start of the Tompkins County Consortium and before people joined after the start of it, predominantly we had the overwhelming majority of people were community rated. So these are all employers of less than 50 employees who were buying community rated health insurance products. And as it would be, all of them were buying it from Excellus Blue Cross Blue Shield historically. Then we had 4 entities that were experience rated, and they were in different types of experience rating models, but suffice it to say they were all experience rated. These are employers all of greater than 50. So we've got City of Cortland, City of Ithaca, County of Tompkins, and the Town of Ithaca. And again, there were some different models in there, and I'll explain a little bit about that when we look at the next slide. And this talks a little bit about risk. When you talk about risk in different types of health insurance models, it really varies from the insurance company's risk to the employer's risk. And I'm just going to walk you through this real quick. It's a little bit of a kind of a continuum of risk here for the 2 different entities. You'll see the top section refers to insurance company financial risk. And you go from low risk to high risk. The lowest risk for an insurance company is self-insurance. So if an employer decides to self-insure, which means they are responsible for paying all the claims, the insurance company is really off the hook in terms of claims experience from a risk perspective. You know, they'll get their administrative fee. Technically, by law, they're required to pay all the claims and do all those things, and there's protections built in there. But from an annual risk perspective, very low to the insurance company. Then you get into different types of experience-rated models. And I mentioned there's all different types. You go anywhere from what is commonly referred to as minimum premium, which looks like self-insurance, but does have a couple of insurance elements in it, where the risk is high to the employer but low to the insurance company. Then you get into retrospective rating arrangements, where there's usually a rate that's given, and then there's a trigger where the insurance company could charge more if the trigger is met. And then there's prospective rating. Prospective rating means basically you get a rate at the beginning of the year, and that rate is good for the whole year. The employer is not at risk for anything above that rate. And at that point, the insurance company, if they don't do a good job of projecting paid claims, if the claims exceed those projections, they're going to be on the hook for that overage. So they're at risk. Now, generally, they'll make it up in the next year's renewal, but suffice it to say, for that year, the insurance company has a much higher element of risk. And then there's community-rated plans. Community-rated plans are similar to prospective rating experience plans. The only difference there is instead of being rated on the experience of one specific employer group, like an experience-rated program would be. It's really rated on the collective of all the small employers that happen to be in that particular insurance model. So they pool everybody together in a community and then rate it based off of that. In those particular environments, the risk is very high to the insurance company. When you flip it around to the employer's perspective, it's exactly the opposite. If you're in a community-rated product, again, your rate is given to you at the beginning of the year. You know that exactly what your expenses for the year. There's no risk that you will pay above that. Same thing when you get to the experience-rated models. When you're prospectively rated, no risk. Retrospective, now there's some risk. A lot of times they'll give you a rate that may be 80% of the full rate, and then if you hit a trigger, they can charge you up to 20% more. So now all of a sudden, you get to the end of the year, and you say, oh, geez, you know what, we missed the trigger. All of a sudden, we've got to pay, Blue Cross or somebody else significantly more money than we anticipated, so there's some risk to the employer. Minimum premium, similar concept. If you miss your paid claims projection, obviously the employer is going to be at risk for those additional claims expenses because, again, the insurance carrier is billing the employer for those claims. Self-insured plan, same thing. If we miss our projection on the claim side of it throughout the year, obviously our expenses are going to be greater than we had anticipated, so we're going to have to make that up at some point. So we're at risk for that as an employer perspective. Does everybody have a pretty good understanding of that?
And I just want to say, if you have questions along the way, please feel free to ask, because this is for your, to be able to digest this and consume this. And Mary Ann has a question. Thank you.
I may have misunderstood the term community rated all these years. It's not a geographical community, it's the insurance company's pool of small employers?
Yeah, if you take Excel's Blue Cross Blue Shield as an example, and they have a community-rated product, let's say just for argument's sake, it's one of the platinum plans that they have available. They're taking their entire population of insureds for all of Excelis. So it's Rochester, Syracuse, Utica, Ithaca, Binghamton, that entire central New York region, everybody that's in that population is being pulled together. It's not, historically, when the Blues were separated, it used to be a little bit more regional. Now it's their entire book of business in the central New York area.
Thank you.
Yep.
So for those of you that aren't sitting at the tables here or at the bench, please come up to the microphone and ask your questions so we can get that on the taped. Steve.
Yes. In terms of our risk model that we have here with the consortium, and we mentioned that it's self-insurance. It's under Article 47 of the New York State Health Insurance Law. In terms of the mechanics of it, if you will, basically whenever the employers pay the premiums, they come into the consortium through the county's treasurer's office and controller's office. Obviously, Steve Thayer mentioned that he's the CFO. They're the ones basically billing and receiving premiums from all the employers. All of those premiums are pooled. So all the money that's collected is pooled. All the risk is shared amongst everybody in the consortium. The premiums are established to cover statistically predicted claims and fixed costs. So when we're looking at our budget is really driving, obviously, what our premium equivalent rates need to be. It drives what our rate increase is going to be from year to year. The consortium has to pay every dollar of claims that comes in. The only caveat there is we do have some insurance protection for large loss claims. It's referred to as stop-loss insurance. If we get above a certain level, they'll reimburse. But the consortium has to pay those claims first before they even get reimbursement from stop-loss. So in essence, the consortium is really responsible for every single dollar that comes in terms of benefit payable. Maintaining reserve accounts. Basically, the important part here is that any of the premium that comes in that's not used to pay for claims or related expenses, all the excess funds are set aside. They're pooled. And basically, we have several elements of reserves that we have to maintain for what they refer to as incurred but not reported claims, which is a claims liability. We also have a reserve for capital surplus. We have developed some additional reserves over the years. Those monies do earn interest, although a little bit these days, not very much, but they are owned jointly by all the employers. So unlike a traditional insurance plan where you would pay your premium in, if there was an overage, that was kept by the insurance company. In this model, the overage stays with the consortium, it gets invested, and we can use it for future budgets to help mitigate rate increases. So basically, one of the things that we're looking at doing over the next, couple of years, and just a quick little side note, we're looking to use some of the excess funds that we have right now to mitigate rate over the next couple of years, and that's certainly a strong positive of what we've been able to do with the consortium. In terms of Article 47, there's a lot of requirements, as Don mentioned, in Article 47 that we have to adhere to. And these are a list of the different sections of Article 47. I'm just going to point to a couple of them, and then we'll get into the the real reason we're here today, which is the plan benefits and disclosure section. But basically, as Don mentioned, we had to have a municipal cooperative agreement in place before we could start the consortium. We also have to have our reserves funded, as I mentioned, and there's all kinds of regulatory requirements relative to those reserves and surplus accounts. We had to purchase stop-loss insurance. We do have to recognize any contingent liabilities that may be out there. We do have to file reports with the state. They do come in and examine the consortium from time to time. We did have an audit of the consortium's first year of operation in 2011, which is somewhat ongoing. They've completed the audit, but we're still trying to wrap up some of their recommendations that they had and make sure that we're adhering to everything that they've wanted. So there's a lot of regulation that goes into it. And the biggest thing that we want to talk about today has to do with the plan benefits. And basically from the New York State Department of Financial Services, they view this consortium as an insurance company. So they're basically looking at this group, and every time they refer to the group in any communication, they talk about it as if it is truly an insurance company. So we do have to think of ourselves in that kind of context, although it's certainly a much different insurance company than the traditional that's out there. But in terms of Article 47, and specifically Section 4709, we highlighted subparagraph B there. The summary plan description shall be subject to regulation as if it were a health insurance subscriber certificate. So basically what that means is that all the plans of benefit that are developed for the consortium basically have to adhere to the same guidelines that Blue Cross Blue Shield has to adhere to in terms of the insurance products that they sell in the marketplace. So we have to have all the same required language. We have to have all the same mandates, definitions, structure, basically everything from soup to nuts in terms of language to satisfy what an insurance company would have to do to file and have approved insurance products that they sell to the marketplace. Now, our plans are a lot different than the traditional. Most of the plans that came into the consortium, especially for the larger employers, were extremely old style, what we refer to as indemnity plans from a long time ago, that we had to kind of try to retrofit into some of the new language that we have today. Obviously, some of the newer models we're talking about are more up to date with what's going on from a benefits perspective in terms of both federal and state legislative requirements. So that being said, one of the things that we want to try to do today is answer a basic question, which is, what is a benefit planner, or what are benefit plans? Benefit plans are basically a contract between a person, their employer, and an insurance company. So basically, as an employee, you're going to have, or as a retiree, some kind of an agreement with your employer that they're going to provide you with some coverage for your medical expenses. From that, the employer is going to go to an insurance company and say, here's what I'd like to provide my employees in terms of coverage for them, maybe their spouse, their dependents, in terms of benefits for them in terms of medical care expense. As part of the health benefit plan, the insurance company will typically contract with service providers, hospitals, physicians, laboratories, et cetera, to provide service at a reduced or agreed upon amount. Now, the way this benefits us, obviously, is if we had to go out and negotiate discounts on our own as one group, just as the consortium, although we're rather large at about 2,300 contracts and 5,000 covered lives, in the overall scheme of things, we're very small. It's good to have the weight of either Excelis or ProAct to go out on behalf of all their customers and negotiate with these facilities and these providers to help us keep our rates as low as possible. And obviously, the lower we can keep the rate of reimbursement, the less claims we're paying out, the lower the premium. Obviously, all that has to be within reason. We want to make sure that people have access to the care that they need, that physicians and hospitals are getting enough funds to provide the care that folks need. So it's always a delicate balance in there. And then the benefit plans must meet minimum federal and state requirements and include all mandated benefits. In terms of what's available in the consortium, we currently have a menu of options that have been developed. Again, when we first started the consortium, a lot of it was developed based off of what everybody had. You know, we looked at all the different plan designs that were throughout the county, from the towns, the villages, the city, the county. We tried to meld plans together where we could. If there was some synergy between plans and it required very little change, we made that happen. But we ended up with a pretty large menu of options, kind of traditional benefit plans. You know, we have indemnity, we have what they call preferred provider organization or PPO type plans, or you pay a copay for physician type services. We had a comprehensive plan, which is kind of a smaller but close to a high deductible health plan. It's a much lower deductible, but there's an upfront deductible and then things are covered. And then we did also develop a Medicare supplement plan not too long ago. And most recently, we've added the Platinum plan to the benefit offerings, and we're continuing to discuss, I'm sorry, the Bronze plan was just added?
Yes.
Yes. Bronze plan was just added, and we're continuing to discuss Gold and Silver. So basically, the idea here is that we want to make sure that both management and labor have a good list of benefit plans available to discuss when they get to collective bargaining. We also want to make sure that we're well situated against the insurance marketplace. If we don't have something available in the consortium that somebody wants, then they're going to look elsewhere for it. So one of the things we want to make sure in terms of our benefit options that are available is that we're keeping up to date with our competitors, if you will, as well. And technically, being an insurance company, our competitors are, you know, Excelis when they sell insurance products, or GHI or MVP and some of the other carriers out in the marketplace. So we need to be well positioned against them. In terms of the different types of benefit models that are out there, there really is an alphabet soup of different types of plans. Some you may be familiar with, some you may not. I even left a couple of them off of here because we don't even have them through the consortium, and they're kind of older styles that are falling off. But indemnity or traditional plans were basically where everybody started in terms of health benefits 20, 30, 40 years ago. It's your traditional paid in full hospital, paid in full medical surgical. You have a major medical type policy with a deductible and some kind of coinsurance with an out-of-pocket max for physician services, medical supplies, durable medical equipment, and things of that nature. Very traditional. Back in the day when these were first offered, prescription drug was included in the major medical portion, so that was subject to a deductible, was subject to coinsurance. Today, they've carved out the prescription drug into separate drug card programs, and we obviously have a litany of those available through the consortium as well. Then as time went on, they started to get into trying to drive patients to certain providers. And that's how we got to these preferred provider organizations. And preferred provider means, obviously, they've got a special deal with the insurance carrier. And as a result of that, there's an incentive built into the plan for you to use those services. And basically, the way they originally started and still are offered today is if you stay in network, going to a preferred provider, you pay a pretty small copay, maybe $10, $15, $20 for an office visit or things of that nature. If you go outside of the network, there's kind of a disincentive. Now it's back to the old traditional major medical style with a much higher deductible and coinsurance that you have to pay, and you may be subject to balance billing because the preferred provider has an agreement with the insurance carrier that whatever they pay or whatever they allow, they're going to accept as payment in full. Where if you go out of network, no such agreement is in place, you're subject to balance billing. It could be a lot of money out of pocket that may not be covered by the insurance plan. Then from preferred provider organizations, we started to get into point of service plans. And this was kind of a model that was hot maybe 10 or 15 years ago where they said, oh, you know what? We're going to have a gatekeeper. We're going to have everybody go to their primary care physician before they can have anything done. So you had to go to your primary care physician, then you had to get referred out. In the end, what they found out is that all it did was increase expense because you force people to go to a primary care physician, they end up going to a specialist anyways. So you paid for another office visit, kind of meaningless. And so those are kind of going away. There's also what they refer to as exclusive provider organizations. The only difference between those and a PPO is no out-of-network benefit. So we didn't really include that on the exhibit because it's really not germane to our conversation today. Health maintenance organizations, you're pretty familiar with those. We talked a little bit about them. Again, kind of a model that was first started back in the 70s and 80s, picked up a lot of steam early on where not only were they going to be the insurance carrier, but they were going to be a provider, the main provider of service. You know, they'd have an urgent care center, they would have physicians on call, you'd go in there for service, so they would control kind of everything. It was heavily managed in terms of people's ability to get to specialists and get outside their small network of physicians. As a result of legislative changes and court actions, all the teeth were kind of taken out of that HMO legislation. HMOs look like insurance companies today. I mean, it's really not that much of a difference. Now we start to get into some things that are a little bit more modern. The high deductible health plans are kind of a newer model that's out there. It's really kind of a regeneration of some old philosophies where people are paying up front a much higher deductible for care. So basically the small things are taken care of out of pocket, and it's really just taking care of catastrophic or major types of services. They do typically come with a health savings account, so you can put money away pre-tax to pay for some of those smaller items. Obviously, with a much higher deductible, the premium's a lot lower, so there's an offset for those. And then there's also the traditional flex spending accounts, which most of you folks are familiar with. In terms of the member's share of cost, there's a number of different elements that impact both the employees and the retirees and their families. Obviously, the very first is premium contributions. You know, right up front, in a lot of collective bargaining agreements, there's an agreement between the labor group and management in terms of how they're going to share or distribute the cost of premium amongst them, whether it's 80% paid by the employer and 20% by employees or whatever the case may be. Then you get into items that are typically included in labor contracts or personnel policies. They talk about share of costs, but they're really benefit driven. So really a little bit different than the premium where it's just a straight sharing of expense. These are more benefit driven where you talk about deductibles, co-insurance amounts, and again, co-insurance is where you're paying a percentage of the cost. Co-payments are where you have a fixed fee. Out-of-network provider balance billings. So again, we talked a little bit about if you go outside a network and they charge something greater than what the insurance company allows, that you could be subject to that. And then non-covered products and services. Obviously, there's a list of covered items. If you go outside that list, you may be exposed to some expense in that regard. Just a quick example of a difference between an indemnity and a PPO plan, just so you have a visual of it. Again, the biggest difference is when you look in-network on the PPO, you'll see co-payments for primary care physician and specialist. When you slide across under indemnity, it's 20% after deductible. Out-of-pocket maxes are a little bit different. You know, in the newer style PPO programs, a bit higher. But again, you're capped out a little bit because you're only paying co-pays in certain areas. Both are covered in full when you talk about inpatient hospitalization. No annual or lifetime maximums, and those are kind of legislative changes that have happened over the years. But just a visual to kind of give you an idea of the base programs that we had when the consortium first started, and these are really the two models that are still predominantly used within the consortium today.
Steve?
Yes.
You were saying with the balance bill?
Yes.
Does that apply to the out-of-pocket maximum?
Does not. So anytime a physician or a hospital charges above the allowed amount of the insurance company, or Excellus in this case, that amount that you have to pay, first off, I would suggest that you certainly talk to them and try to negotiate that down as best you can. But secondarily, any amount you pay above the allowed amount is going to be straight out of pocket, and there's not going to be any cap on that. So it's important to try to find out up front, if you can, you know, how much things are going to cost. You know, talk to the insurance carrier to see if you can get an idea of what the allowances might be, and then from there, you'll have an idea of what your out-of-pocket exposure might be. Or, obviously, if you can find another physician or hospital in the network, that's obviously the easiest way to prevent that from occurring. Talking a little bit about specifically prescription drug programs, and I mentioned that we had a myriad of different prescription drug plans that came into the consortium. Some of them were still included in the traditional major medical kind of model. Most of them were prescription drug card, where a member has a card, they show it at the pharmacy, and they pay a copay for their particular medication that they need, and then the transaction's done. The insurance company takes care of it behind the scenes, or in this case, PROACT takes care of it behind the scenes. In a two-tier model, it's pretty simple. You have either brand name drugs or generic drugs. Pretty bland, pretty simple. You pay a copay for a generic drug, usually a lower copay, $5 or $10. You may pay a bit of a higher copay for brand name drugs, maybe $20, $25, $30, but it's very little managed care, very little utilization management over those types of programs. Then you get into what we call three-tier formulary type programs. And these types of programs use a prescription drug formulary that's developed by the prescription benefit manager. And again, the prescription benefit manager is going to use a pharmacy and therapeutics committee to evaluate all the drugs, and they'll place them into three different categories. The first category, or tier one, is generic medications. Then they'll take the brand name drugs and kind of divide them up into tier two, which they refer to as preferred, and tier three, which is non-preferred. Now, the differential between tier two and tier three for brand name drugs is not only monetarily driven. There's a lot of reasons why drugs are placed in different classifications. A lot of it has to do with the effectiveness. You know, some drugs that are a higher cost are sometimes in tier two because they're extremely effective. A lot of the new medications that hit the marketplace that don't have generics available end up in tier three until they're proven. So there's a lot of different reasons why drugs are listed in those two different levels, and not all of it is straight monetarily driven. Today, we're getting into newer arrangements where we have 4-tier and even more than that today. But the 4th tier today is typically referring to specialty medications. So it takes the traditional 3-tier model and adds another category for specialty drugs, which are very, very expensive, very high cost, and puts a higher copay on those. This is just a listing of the 2- and 3-tier models that we currently have available through the consortium. The only caveat that I would mention here is that for the metal level plans, the metal level plans drug plan is the only drug plan available for those programs. All the other plans that we have, whether it's indemnity or PPO, you could pick and choose one of these drug plans to match up with it. So it's a little bit of a different modeling that we've been using over the last several years. The next thing I want to talk to you a little bit about is something referred to as actuarial value. Now, some of you folks that are on the Joint Committee or on some of the other committees have heard some discussion about this, but it is important to talk about in terms of benefit plans, because this is one of the newer concepts, modeling that's out there that's really driving the way insurance products are being developed today. Historically, we really didn't have a way to kind of grade or rate different insurance plans. Everybody knew they had health insurance, but nobody really had a way to tell you exactly how good or bad your coverage was. I mean, you could kind of look at it and make a general assumption, but we didn't have a model that we could use to do that. One of the offshoots of the Affordable Care Act and the development of all the rules and regulations and operational mechanisms for that was the Centers of Medicare and Medicaid Services developed an actuarial value calculator. And this calculator basically takes a plan design and will return the amount or the percentage of care that that plan is expected to cover for the average person. So it really gives us a way to kind of evaluate plans now and kind of grade them against each other. And as we have talked in the past about the calculator, as an example for a platinum plan, that particular plan is supposed to provide approximately 90% of the health care costs for an average individual in a given year. So if we want to get a model that's close to a platinum plan, we load the benefits in, we use the actual value calculator, it'll return a value to us, and it'll tell us if we have a benefit plan that's comparable to a platinum plan. I can tell you that the majority of plans that the consortium had prior to the development of a couple of the metal level plans that we currently have available, for the most part, we're all well above the platinum plan range. especially some of the older models that we had. So one of the things that we're talking about, and obviously this actuarial value calculator kind of leans us towards, is not only talking about fixed cost items when we talk about health insurance, but really talking about the distribution of costs between how much the plan is likely to pay and how much the member is likely to pay. And that's a little bit different conversation than what we've had in the past. So it really does talk about the value of health insurance and what dollars the member is going to pay out of their pocket and what we expect to pay from a plan perspective. Now, one of the reasons that this is very important today is, as you know, over the last couple of decades, health insurance costs have increased much faster than CPI, typically about 3 times the rate of CPI, if you look over the history. And there's a lot of reasons for that. You know, people think of inflation and you just think about the cost of care from one year to the next. Well, in health insurance or medical care, it's a lot more than that. We do have the traditional medical care inflation. You know, you go for an office visit this year, you go next year, there's a 3% increase or whatever it is. That's your general rate of inflation on those items. However, in health insurance, we've got a lot of other elements like advancements in medical technology. Every time a new medical procedure hits the marketplace, and I like to use the example of joint replacements because it's kind of a newer thing that it's very prominent, that a lot of people are getting it. Knee replacements, hip replacements, shoulder replacements. 20 years ago, those weren't included in health insurance plans because they didn't exist. Today, because we cover surgery, now we cover those types of things because medical technologies have added that to the things that we have available to us from a medical care perspective. Same thing with advancements in pharmaceuticals. You know, we've always covered prescription drugs. But again, 20 years ago, we didn't have Lipitor, we didn't have Nexium, we didn't have a lot of these things that are on the marketplace that we all benefit from today. Certainly keeps us a lot healthier, but obviously those have been weaved into the costs of the health insurance program. We've had a myriad of federal and state mandated benefits. And when we talk about kind of the nuts and bolts of benefits, you'll see why, because the legislations that were passed and the rules that were established more than 40 years ago that kind of developed the standard for health insurance, obviously language was very old, they need to be augmented over time, and we have to adhere to all those federal and state mandates. And I have highlighted here the decrease in the value of cost-sharing items. This is something that we don't normally think too much about, but taking as an example a deductible of $100. If we've had a deductible of $100 for 20 years, obviously 20 years ago $100 meant something different than it means today. So if you just apply just kind of the reverse inflation to that and kind of look at it from a value perspective of what it would be equal to today, obviously it doesn't have that same economic value today as it had at one time. And then medical malpractice, federal state taxes and fees, which are kind of built into our health insurance programs today, which sometimes, but not more sometimes, they always bother me in terms of how they add to cost. And one of the reasons why in Don's slide that he mentioned that percentage of paid claims is down a little bit over the last couple of years is because of some of the new federal fees that we have to pay. So it's taking up a bigger chunk of our budget. So. And then medical malpractice also does have an impact, and certainly the insurance costs and litigation associated with it affects many of the providers and also affects the cost of care. Benefit plans haven't kept pace predominantly with changes that have occurred in health insurance over the years and medical care over the years. And these are some of the reasons why in the public sector that's the case. I mentioned health insurance kind of evolves over time as new therapies come out, new drugs hit the marketplace, new mandates come about. However, we always have about 3 to 5 years between contracts in most municipal environments. A lot of them are 3-year contracts, some go as far as 5. And a lot of those items are locked in. Well, they're locked in for 3 years while everything else around us is changing. So that kind of puts us behind the curve a little bit. Health insurance trends outpace the cost-sharing changes that are typically made. Lack of focus on the true cost distribution. Again, we're getting to that focus with the kind of the ACA actuarial value models. Plans are negotiated line item by line item, which obviously raises a lot of questions and concern. And what is viewed as a modest premium increase from an insurance perspective is viewed from a user perspective as a major benefit increase. So when you talk about increasing someone's deductible by $50, To them, that's a good-sized number. A $50 increase is a pretty good-sized number. In terms of impact on overall insurance premium, it's 0.1%. So the weighted impact is viewed differently depending on your perspective. And just to give you a visual of what we mean by this, next slide, if you would. This is just one of our clients. It's the OCM BOCES up in Syracuse, New York. And this just shows for the last 23 years, and this goes from 1991 to 2012, 2013, what changes they made to their benefit plan in comparison to what was going on with Medicare from a cost-sharing perspective. And again, it just kind of gives you a visual at what we mean when we say that, we haven't really kept pace in some areas. When you look at OCM BOCES deductible and out-of-pocket maximum, they're flatlined. It's been $50 for the last 23 years for deductible. It's been a $400 out-of-pocket maximum for 23 years. Then you look at Medicare Part B. The premium, the deductible, those have all kind of increased a little bit over time. Then you look at Medicare Part A deductible. And over that 23 years, it's almost doubled. It's gone from about $600 up to $1,200. So, Medicare has been changing some of these elements of the plan to kind of try to keep pace. And this just gives you a visual of, if you don't keep pace, how far you get away from where everybody else is. And just as an example of that. We talked a little bit about the ACA meta level plans, and for those of you who are on the Joint Committee, you've heard this to nauseum, and I apologize, but basically there's 4 standard levels of benefit plan available through the Affordable Care Act health insurance exchanges, whether it's a state exchange or a federal exchange, and they're broken down by, again, the percentage of the average person's care that the plan is going to cover. So a platinum plan is 90%, gold 80%, silver 70%, and bronze 60%. I just was reading an article as I was sitting down waiting for the presentation to start, and it was about the rate of increase for 2016 on the health insurance exchange programs. And they're, just as an aside, they're saying that the average increase is going to be about 12% for 2016. I think we're looking at something much less than that, just as an FYI, for the consortium. And also, kind of an interesting statistic, they said that most of the people purchasing health insurance coverage in the exchanges were in the silver plan. 67% of all the people who enrolled through a health insurance exchange purchased the silver plan. So just as a point of information on where the ACA kind of comparative model is versus where we are. In terms of ACA 2015 mandated limits, there are set limits in terms of how high a deductible could be, how high an out-of-pocket maximum could be for both individuals and families, and this is something new. There never was a limit historically on a lot of the programs from this perspective. This year, it's $6,600 for an individual and $13,200 for a family, both maximum deductible and maximum out-of-pocket. So in a given year, an individual could never pay under any insurance model that's available today more than $6,600. Most of our modeling through the consortium is much less than that, but these are the mandated limits, so you're aware of those. Also, there can be no annual limit or lifetime limit on essential health benefits. This is something that changed with the ACA. Historically, a lot of programs had $1 million lifetime maximum built into the program. Those have all been removed at this point. So when we start to see cost increases, that's some of the area where we're seeing it. We did have one client last year who had one person spend $1.8 million, where under the old model they would have been capped out. Not sure who would have paid the other $800,000, but suffice it to say that the plan did pick that up because of the change. In terms of the actuarial value model, and this is a little hard to see, but we wanted to give you an example of what we may be looking at from typical gold plan to one of our more traditional models that we have available through the consortium. And you can see just how much it can vary from plan to plan. This particular gold plan, this is the one we've been talking about for the last couple of years with the consortium. We're actually a little bit above the range at this point. We're at 82.4%. And the range is plus or minus 2% from starting with 80 as the base. So we're just slightly above where we want to be for the gold, but that's certainly within reason because we've been talking about it for a little while.
Steve?
Yes.
Can I go back to out-of-pocket expenses?
Sure, of course.
is my understanding, which I think you say there, is if you're out of network and they charge more than what the insurance company's going to pay, there is no limit, so that you could.
That's correct.
You could still go bankrupt.
Well, you could, yeah, certainly if you're out of network. And that's, one of the reasons why the consortium wants to make sure we maintain a really solid relationship with a company that has a very robust network, is to prevent that from occurring. But you're right. The out-of-pocket max only applies to those things that are covered in network under the program, or out of network under the program, up to the allowed amount. So any balance billings that the provider may have would not be included in that maximum. So you have a couple examples of the actuarial value tabling, and you can see what's built into that. I'm not going to go into too much depth on that today, but it's important to have at least a base understanding, because one of the things that we do talk about with these newer style benefit plans, and I think it's something that's critical for people to understand, because it is so different than the traditional health insurance and traditional collective bargaining modeling that we've had historically, is that these plans are made, to change over time. And the reason they're made to change over time is because the plan is supposed to maintain its actuarial value. So while everything else is changing around us, this benefit plan is supposed to maintain the cost distribution between member and plan. And when I say member, it's average member. Now again, if you're a really high user of the plan, your percentage of care cost is actually going to be lower than the average, because you're using so much of the benefit plan. If you're a lesser user of the plan, it may be higher. So it's a little bit reverse of what you might think typically. But maintaining an actuarial value is really a cornerstone of these types of programs. And again, we talk about the different rates, the percentages. Each metal plan will be reviewed on an annual basis. The way we've got it set up through the consortium is that changes cannot happen any more frequently than annually, that they have to be approved by November 1st by the board of directors, and we certainly would take it through all the committees to make sure everybody's aware of what the changes are being recommended. Those changes will be communicated out to members by December 1st each year, and that we would maintain and adhere to a certain definition in terms of actuarial value. Now, one of the things that we built into the definition of the calculation of the actuarial value is kind of a safety valve in case the Affordable Care Act isn't with us anymore sometime in the future. We do have a provision built in there where we would use an outside actuary, an independent actuary, to develop the actuarial values of the program using similar methodologies to what the federal government has established.
Steve?
Yes.
I have a question.
Yes.
We're developing the Platinum partly to coincide with ACA and partly because it is a less valuable plan.
Lower premium, a little less benefit, yes.
So about using this actuarial percentage, if Platinum is 90%, about where are we with some of our better quality plans that we're offering now?
Probably as high as 96%.
Okay.
With a couple of them. I mean, we've got a couple plans still out there with, it may even be a little bit higher than that. We've got a couple of retiree programs out there with really, really low prescription drug copays. It may even be a little bit higher than that.
Okay, thanks.
So before Steve goes on, this is really the foundation for how benefit plans are created and what they're all about. So I'll just give you a second just to kind of internalize all this, and then
Just a second?
Exactly. That's all you get, because we're fast learners. And then, so we'll be referring back to this as we move on through the second part of this. And so now let Steve talk about mandates.
Yeah, this is the last section in terms from a technical perspective, and I apologize. I know it's kind of tedious to go through a lot of this technical stuff, but it's important to have an understanding of what we're dealing with from a regulatory perspective and also from an insurance marketplace perspective before we start talking about our actual benefit plans themselves and how we develop them and then how you use them, and also how the provider networks weave into those. In New York State, we have certain requirements in terms of minimum benefits that we have to build into our benefit programs. And I mentioned that these particular regulations were developed some 40-plus years ago. And if you actually read them, you probably find them to be slightly comical, because it talks about, basic hospital services, as an example, has to have at least 30 days available for inpatient hospital care, has to pay at least $100 per day for inpatient care. I mean, if you refer that to today, it's not even close to covering enough to satisfy someone's requirements in terms of what they need. But that's really the starting point of all the benefit plans, that we have to meet these minimum requirements. Then from there, we have to make sure that we meet all the Affordable Care Act minimum essential benefits. So we've got the state level, and now we have a federal level. Historically, before the Affordable Care Act, the federal government really stayed out of the health insurance arena, and it was really left up to states. Every state had their own Department of Insurance. Every state had their own regulations. They basically dictated how these modelings would be developed. But now came the Patient Protection Affordable Care Act, or the ACA, and it created another layer of essential benefits, or minimum requirements, if you will, that we have to build into benefit programs. Now, in New York State, because we already had our own minimum benefits and a laundry list of mandates that have come out that augmented those minimum benefits over the last 40 years, and I would say probably hundreds, not tens, but hundreds of mandates that have probably come out over the years. Our programs are probably, we're probably better situated to adapt to these ACA requirements than a lot of other states. You may have heard that when they were going through the development of the ACA and rolling it out, a lot of states were, oh, this is going to cause our premiums to go up 40% or 30%. I even heard as high as 50%. The reason for that was these minimum requirements were things that they weren't requiring to be covered. So a lot of their plans either didn't cover them or had a real high cost share element associated with them. Where in New York, we predominantly were covering all these. And throughout the Northeast, Mass, same thing. All these were pretty much requirements. And you can see the list of what's required in terms of the ACA there in slide 47. I mentioned about mandates on slide 48. Just from 1993 to 2003, there were 30 new benefit mandates that were put on insurance plans. Since 2003 through 2013, which includes the Affordable Care Act, there are 51 more new mandates that were put on. Some of these mandates are to keep up with technology. I mentioned that the minimum requirements, if you read those, you would actually probably laugh at them, because some of them, one of the things it refers to is an iron lung. I don't know if I've ever seen an iron lung, to be honest with you. So that's not obviously required anymore, but there's other things that have taken that place of that obviously are built in. And one of the things that is a reality, it's not good, bad, or indifferent, it's a reality, is that all of these mandated changes have come without discussion. Without discussion about how much is this going to raise cost, how much is this changing benefit, things of that nature, those typical discussions that we have in terms of when elements of benefit plans or collective bargaining agreements are changing. These types of things did not come with that same type of discussion. So it's just a recognition of what's been added over the years. And if you look at slide 49, this is just a highlight of some of them. Well child visits, that was a New York State mandate. Now we have well care for everybody, which is a federal mandate. Mental health parity, we had a state mandate. Now we have a federal one that covers that as well. You can go through the list on and on. Dependent to age 26 coverage on the federal level, dependent to age 29 coverage on the state level, same-sex marriage law in New York State, Timothy's Law. It just goes on and on and on, and there's always new things being discussed all the time. The other thing that we have from a regulatory perspective is a restriction on what you can exclude. So there's only certain things that you can actually not cover in a health insurance program. And this is a list of the basic exclusions that you can have in a program. So from aviation, which is kind of an interesting exclusion, dental services, experimental or investigational treatments. Sometimes there's experiments that are taking place at hospitals and physicians. Those can be excluded. Felony participation, so if you're caught robbing a bank and you get hurt, that's not going to be covered. No fault is a pretty common one, military service, and certainly you can go through the list. War predominantly is not covered because of the fact that typically if you're in the military, it's covered by the federal military health insurance program. Workers' compensation obviously is an element. If you do, as an employer, have people out on workers' compensation, you can reach out to Excelis to let them know to make sure that there's not duplicative coverage in those areas. So that's just a side note on that. But basically, these are the list of exclusions that we have for health insurance programs. And now that we're done with that very dry and boring explanation of what the building blocks of health insurance are, I think we're going to take a quick break, and then we're going to get into some, I think, a little bit more interesting discussion after that.
Actually, right after the break is it's the really interesting part. So there's food over here, and I just want to acknowledge that both Excelis and ProAct have donated these healthy snacks for your enjoyment. I would guess that we have another hour from now, so if you have a parking meter that's going to run out at 11, this is a good opportunity to feed that meter. And there's a restroom here, and we'd like to get back as soon as possible. If you can do the parking meter and get back in 5 minutes, that'd be great. Thank you. And now we're going to talk about how the nuts and bolts of how we actually work with the consortium in changing and creating a benefit plan. And we'll take our resident expert, Steve Losey.
Thanks, Don. Now that we've kind of gone through all the regulatory requirements and a lot of the boring information about benefit plans themselves, this gets a little bit more specific to the consortium and how the consortium operates, how we're planning on operating going forward, things that we need to do if we want to continue to have new benefit models available, continue to look at different strategies to try to make sure that we're providing excellent health insurance coverage at reasonable rates. So basically, the first thing we want to talk about is specifically the consortium and how we get ideas for new benefit plans. Basically, any types of new plans or potential modifications to old plans come generally from within the consortium or come from outside the consortium in terms of people who are looking at the consortium as a possibility of joining. We've talked to, Don and I have gone out and spoken with a lot of different towns and villages, some of them in Cortland County, some of them around here. A lot of them have different types of plans than even what we have available today. We've talked to a couple entities that do have a silver plan, so some of the ideas in terms of creating a silver plan obviously comes from our need to try to satisfy what other people are looking for, what we're looking for inside the consortium. Once we get those ideas presented, it's up to my staff to kind of research and present draft plans back to the various committees and the consortium for consideration. We look at what's going on in the marketplace, we look at what people's needs are, we look at what keeps us competitive from an overall cost perspective, and then we try to at least get the basic modeling together and then have some discussions about that. Once that occurs, we'll take it to the various committees. The Joint Committee on Plan, Structure, and Design obviously is an important element of that, as well as the Audit and Finance Committee. One from a benefit perspective, the other one from a cost perspective. We have to make sure that not only is the benefit plan something that the consortium wants to offer, but it's priced appropriately. Then we also have to go through the process of having any new plan design or any change to a plan approved by the New York State Department of Financial Services, which is a process. It's a manual process that we have to go through, and it's kind of a long process. So we do have to allot time for that. And I mentioned, again, this is just the same slide again for 4709B, which says that we have to adhere to those same requirements that the insurance companies have to adhere to. And they do review the plan documents just like they would review an insurance certificate. The only difference being is that the insurance companies actually purchase a mechanism where they can submit documents electronically. It's an expensive item to have. It's not something that's feasible for us, unfortunately, so we're stuck in kind of a manual review and response process that takes a bit more time to get through, and we're trying to work with the department to kind of speed that up and streamline that a bit. Now, in terms of the basic building blocks of developing a health insurance plan for offering, the very first thing we have to decide is what kind of style do we want the plan to be. You know, today, I would say that probably 99% of the plans that are out there are closer to a PPO than they are anything. You know, preferred provider organization plan where you've got in-network benefit versus an out-of-network benefit. You've got negotiated discounts with certain providers, typically copay driven. Even when you look at the some of the ACA level plans, the platinum and the gold, they very much look like PPO programs. Maybe with an upfront deductible. When you get down to the silver and the bronze, those are more like high deductible health plans. But predominantly today, you're seeing more PPO probably offered in high deductible health plan than anything else. Then who is going to be covered under the plan? You have to go through that element. Make sure you have all the New York State minimum and mandated benefits. Make sure you have all the ACA essential benefits. Make sure you have your basic list of exclusions included. Those are all required elements. Those aren't even really up for discussion. But there are some elements that do require some thought, that do require some discussion. For instance, and this is probably going to be news to some folks, but in terms of who's covered under a program, there's some people that are required to be covered and some people that quite frankly aren't required to be covered. Basically, if you're going to offer health insurance in New York State, you have to provide coverage obviously to the insurance contract holder, the employee or the retiree, as the primary person that's being insured. You also have to provide coverage to their dependent children. So we have to provide coverage up to their 26th birthday federally. We have handicapped dependents that we have to provide coverage to, and also the young adult option in New York State. In New York State, we have a provision where adult dependent children, up till their 30th birthday, so after their 26th birthday and up to their 30th, they could actually buy the same program that the parent has as an individual. They would have their own contract. There's certain requirements that you have to meet. You have to reside in New York and some other elements. But there's that option where people could have the same coverage. They'd have to pay 100% of the cost, but obviously we give them access to care and coverage that they may not otherwise have access to. There's also things referred to as qualified medical child support orders. So if you're required to cover children for whatever reason legally, those are mandated to be covered. And then COBRA. So if you lose employment, if you were no longer qualify as a dependent or as a spouse, COBRA obviously is a requirement where people have to be offered coverage. Again, they would have to pay for it on their own. It could be up to 102% of the premium, but those are all required elements. Optional elements are, believe it or not, legal spouses. Spouses are not mandated to be covered in New York State or by federal law. And one of the big trends that we're seeing in the private sector is that a lot of companies, because of the Affordable Care Act and the requirement that all adults have to have coverage, and all employers now have to offer coverage, a lot of plans, I say a lot, there's a number of plans in the private sector, especially the larger employers, that are no longer covering spouses. And that would include domestic partners and same-sex spouses. They're covering the dependent children, they're covering the employee, but they saw that as an avenue to reduce expenses pretty significantly. If you look at all the medical expenses paid for by a health insurance plan, about 30% of those costs are driven by spouses. So it's a pretty good sized number. You have the option of covering domestic partners, and you have the option in New York State of covering dependent children up to the age of 30. And that's what they refer to as a make available rider. A lot of times, especially in New York State law, there are certain elements of the legislation that have been passed over the years in terms of health insurance laws where they make insurance companies offer it. Not everybody has to buy it, but they have to offer it. And that's what they call a make available option. And that's what this dependent to age 20 or age 30 option is. The insurance companies have to have it available. If an employer wants it, they can have it. Obviously, there are costs associated with it. You're insuring people for a longer period of time. There's more bodies than under the insurance plan. So there is a factor that goes into premium as a result of that, but that's something that's available to you. Then you get into a lot of trickier areas in terms of decisions. Eligibility is pretty simple. Most people do cover spouses, especially in the municipal environment. You all cover the dependent children, pretty much up to the mandated requirements. But then we get into elements that are much different when you go from employer to employer. First and foremost, member cost sharing items and levels. Where are we going to set the deductible? Where are we going to set the co-insurance percentage? What the co-payments are going to look like? Any type of limits in terms of out-of-pocket maximums and things of that nature. At what level are we going to set those? Now, if we're trying to meet the definition of the Affordable Care Act in terms of the metal level plans, these are all things that are manipulated up or down to get you into that range. And when you're looking at those options, and we've had this discussion, certainly at the joint committee level, if you say, okay, the model looks pretty good, but what if we wanted to lower the deductible? Well, if we lower the deductible, then we have to manipulate something else to kind of keep it in the range of value. So it's kind of a give and take in all those different areas to come up with the right structure to keep it within that value level. In the old days, there was a lot of different options, and we still have them with the prescription drug copays. You saw the list of options. I think there's still 11 or 12 of them that we have available today. We've tried to come up with enough different variables that everybody has something that might be appealing to them from a collective bargaining perspective, but there really is a myriad of different models that we could use for all these different elements. Then you get into out-of-network reimbursement methodology, and this gets to the questions about, what's my exposure above and beyond what the insurance company allows, whether it's ProAct or Excelis. Basically, the way that we pay out-of-network claims today is a bit different than it used to be. Historically, it used to be pretty much driven off of the insurance company's average reimbursement for their provider group. Then the New York State Attorney General decided to sue all the insurance companies in the state because of their out-of-network reimbursement methodologies. So today we're either in a charge-based area where they're paying a percentage of charges, or we're in an area where they're using the Medicare fee schedule as the basis of determining out-of-network reimbursement. And it could be anything in between those. But it has to be a reasonable level. The State Attorney General's office didn't think that the insurance companies were paying a reasonable level, and that's why the suit happened. I guess the law of unintended consequences is, though, when you remove those lower fees, obviously you're increasing the fees and you're increasing costs. So everybody was looking for ways to kind of mitigate that to some extent, and they really relied on that Medicare fee schedule as the way to do it. If it's acceptable to Medicare, it should be acceptable to others. And for the most part, with Excelis, the highest I think is 150% of the Medicare fee schedule. Yes. Okay. So it's greater than 100% of the Medicare fee schedule. It's a percentage above that and out-of-network reimbursement. Then we can also look at day limitations. Now, historically, we used to look at even inpatient hospital day limitations. Today, can't really do that. It's mandated now that it's full year coverage. We used to have contracts that were 30-day, 60-day, 90-day, 120-day in network, but they've kind of gotten away from that. Now we're talking about things like, therapy services, rehab. We used to talk about day limitations even with mental health care. You can't do that anymore because of the mental health parity laws. So there's a limited number of elements that we can talk about where you can still cap the number of days that you could go for certain services. And these are some of the common ones. Physical therapy, speech therapy, and physical rehabilitation services are kind of common ones. And then we still do have some optional benefits. They're fewer and farther between. The further we go down the timeline, the less and less options we have available because so many of them are being mandated. But we still do have a few elements: acupuncture, vision care, hearing, some dental services, wellness. There's a few other ones that we could add to the list that could be included in health plans and are included in some health plans that we could talk about in terms of options that are available. In terms of changing programs, we've got an existing plan called Plan A, and we want to change that program to something else. How does that occur under our traditional style programs? And then we'll talk a little bit about how that occurs under our ACA programs as well, metal level plans as well. But basically under our old style plan, so the plan that you had when you came into the consortium, whether it was an indemnity plan or a PPO plan, there were a set schedule of benefits, there was a set deductible, copay, out-of-pocket maximum, whatever the case may be. If either management or labor wanted to change that benefit plan, obviously you would take it back to the collective bargaining process, or if it's a non-bargained environment, you take it back to your legislature or your governing body, or it might be a personnel policy that would review it, but certainly someone has to make that decision or collectively make that decision to change the plan. A very important part of the discussion is that the consortium can't unilaterally change any benefit plan that an employer is offering. One of the things that we did when we first started the consortium was where we had similar plans, let's say like a $10 PPO plan, but there were some differences. We basically elevated everybody up to the higher level plan to kind of meld them into one program so we didn't diminish anybody's benefit. But we cannot unilaterally, from a consortium perspective, change anyone's benefits. Obviously, those are governed by their collective bargaining agreements, and they have those rights guaranteed to them. Each municipality has their own group number and has selected their own plan offerings per their agreements and policies. This is another challenge that we have within the consortium. We have right now 27 different benefit models that we have up and running amongst our, 17 municipalities. Now, ideally, we'd like to trim those down a little bit if we could, but we have to go, obviously there's processes that have to be gone through in order for that to occur. Where we can eliminate some of the older plans, we've done that, where people have negotiated out of them and they're just not in use anymore. But for the most part, we're still running a pretty comprehensive list of benefit plans to make sure we're satisfying all the employer's needs. If you did negotiate a new plan, or if you developed a new plan for your municipality or your collective bargaining unit, basically you have to make sure and get in touch with Beth and Ashley to coordinate the new plan in terms of the offering. We typically say that you really should allow 60 to 90 days for that to occur, especially if it's a situation where you're maybe segregating a collective bargaining unit based on data hire or actives versus retirees, and you're moving people out of one subgroup into another. A little bit more complicated, and we just need to make sure that those happen in a real good and efficient manner. So that's kind of the process under the old style programs. Under the metal level plans, a little bit different. If you negotiate one of the metal level plans in, or if you already have, and you're currently utilizing those, and some of our newer partners that have come in, Village of Homer specifically, it has a metal level plan. This is the process that we envision following for changes to those programs in the future. Basically, we're going to go through the process of calculating the actuarial value. We're going to do that on an ongoing basis, trying to see where we stand. We're doing that right now for all the plans for this year. Once we get the AV determined, we'll have to look and see if it's outside the standard deviation range. If it is, then we'll have to come up with some ideas in terms of strategies to get it back inside the standard deviation. We'll start to review those with the joint committee on plan structure and design in terms of what elements we may look to alter. Once the joint committee has reviewed it, they'll make a recommendation to the board of directors. The board of directors then would be charged with approving any plan changes that would occur. Notifications would have to go out to any covered members that would be affected. So anybody that's in those particular plans would get some kind of a letter or notice indicating that their plan is changing and here's what the changes are to be effective January 1. Yes?
Would that notification be likely to come from the consortium?
Consortium.
Okay.
Yep. And then all the changes would obviously be coordinated with Excellus and ProAct, and the changes would only occur January 1st following approval. So with the metal level plans, no changes would occur more frequently than once annually. If it happens annually, it does not necessarily mean that it's going to be a change every single year, but the evaluation process is going to happen every single year. Once we slide outside the standard deviation, then we need to have discussions about getting it back in line at some point. And that's the process that we envision going through with plan design. So, when you look at all the different regulations and rules that are involved, obviously there's a lot of things that come into play from a collective bargaining perspective in terms of contract and things of that nature. This is just trying to give you the nuts and bolts of how we're looking at, from a consortium perspective, developing these plans, working with all the various committees, working with the board of directors to roll them out, and then also changing them over time. So that kind of gives you a little bit of an understanding of the process we're going through, and obviously you can build that into your own processes at the local level when you start to talk with your labor groups about plan design and things of that nature. And with that, we'll turn it back over.
Sure. So I always like to use a visual, and you've probably seen people operate a backhoe and they're using their feet and they're using their hands and their fingers and they're moving all these levers. Well, we just determined all the levers that we have to move on this backhoe that we're operating. And so that's really what this section was all about, so you can understand different things that are possible to be discussed and changed as we move forward and try to stay abreast of the industry that's changing around us. So with that, we're going to give Steve a chance actually to drink some water and take a rest on his voice, and give Beth and Ashley a chance.
So I'm going to Kilpatrick's, is that what you're saying?
No, you're not going to Kilpatrick's yet. Another half an hour.
Can I throw in a possibly brief theoretical question?
Sure.
Earlier, you talked about the degree to which the insurance department reviews our plans against the same standards that a commercial company's plans would be reviewed. One of the reasons we formed the consortium was to have a little more control over our plans. Can you estimate the degree of discretion that we or a commercial company has in plan design? Can we design a better plan than a commercial company?
Yes. We have,
I like that confidence.
Yeah, we have many plans that are much better than what the commercial carriers are offering today. I mean, most of the plans that we're offering, they're trying to get rid of any of those old plans that are still hanging around. So from that perspective, yes, we can still develop plans that are better than the traditional insurance models that are out there. And we have the same, both entities have the same ability to change the same portions of the plan. Now, to what degree do you change them? So, we may say that we feel that, $500 deductible is reasonable, and the insurance industry may say $1,000. We have the flexibility to change that. Unfortunately or unfortunately, they've limited the number of elements that we can discuss.
That bulleted list?
Yeah. The number of elements that we can discuss today is truncated significantly from what it was 20 years ago, which is probably a good thing, because 20 years ago it was so complex. I mean, if we started talking about lengths of inpatient hospital stay and all this other stuff, forget it. We lose everybody after the first 5 minutes. Now we're only talking primarily about cost-sharing elements, deductibles, out-of-pockets, co-pays, things of that nature, things people really can get a good comprehensive understanding of before they agree to it. So I think from that perspective, it's the same elements, but our range in terms of what we could do versus what the insurance companies are willing to do is probably much greater than what the private sector would do.
I think I get it. Thanks.
Good question. Any other questions? All right. Oh, good. Bev, can you come up so we can tape you? Thank you.
Do all the plans that the consortium offers use the same provider network?
Yes. Every single plan that we offer through the consortium uses ProAct for pharmacy and also Excellus Blue Cross Blue Shield's network. And just as a side note, Excellus Blue Cross Blue Shield as a company only has one network. So when we access the provider network through Excellus, we're getting the entire provider network through Excellus. It includes, and they're going to talk about it a little bit in the slideshow, it includes their national Blue Card network. So not only do we get Excellus's Blue Cross Blue Shield network, but we get all of the Blue Cross Blue Shield networks, not only throughout the United States, but internationally.
So that means that in terms of reimbursing to providers, it's the same across all plans?
Yes, that's exactly right.
Other questions? Okay, Beth, Ashley?
Great. Good questions. And yes, now you are like the health insurance plans at Excelis that have to make decisions, especially when it comes to the metal level plans. And when you review them, that's something that happens at Excelis. Each year, we will be looking at those to make sure they stay within the standard deviations. We're going to talk about using the plan. We'll talk about what a type of service is and what decisions go into selecting where to receive care. And then I'll go over what actually happens to a claim when it comes in-house. So as you can see, there's many different areas where you can select services, one from your primary care. There's diagnostic coverage, radiology, aftercare, emergency room, urgent care, specialty services, anesthesia, therapies, and rehabilitation pharmacy also. The other thing that you'll see is the decision-making process. Through this, there's a lot of things that happen when you decide, oh, I'm not feeling well, I need to leave work, I need to go to the doctor. Do I go to the doctor? Do I go to the emergency room? So there's a lot of decision-making abilities that you as the patient have, but also it's thinking about the out-of-pocket expenses that will come to you directly, but also the cost that is bared by the consortium. So each plan within the consortium has different out-of-pocket costs. However, as Bev just indicated in her question, that reimbursement is what we're paying the provider, and that's pretty much the same. So a surgery under a PPO or an indemnity plan, or even the metal level plans that are now available, the reimbursement back to the provider is the same. It's what's coming out of your pocket that's different. Any questions on that slide? Okay. So what really happens when a claim comes into Excelis Blue Cross? This is just a quick little flow chart. Years ago, it used to be a paper copy. Now everything's electronic. We do an in-depth provider community reach out as to when new coding comes on board. So they're billing us electronically. The claim comes in-house. We process the claim. And what happens is that claim goes through our system, and there are numerous checks and balances that occur. So it's first checking to see if you're on the plan, what plan you have, if you're a female, if your date of birth is correct, if you're on the plan, if you're not on the plan, if you're the spouse, if you're the dependent. So it's checking all these little categories. And then it's also going back to say, how is this service covered? What's the deductible? What's the coinsurance? And then it goes through the system. With that, just so everyone's aware, we actually have what's called outside recovery agencies, and they data mine our systems to make sure that claims are processing correctly. They have an entire different set of algorithms that they put claims through. So if there's fraud happening where maybe somebody's bundling something, the claim gets unbundled. So for the most cost-efficient claim processing, systems in this day and age have come a long way. Years ago, we used to have students to age 25, and they had to be a full-time college student, or we would not be able to know that somebody had to be off the policy because they were no longer your dependent. We now have ways to catch that right at the system level. So we've come a long way with claim processing and adjudication.
And for the prescription plan, it is a very similar process, but picture it's all happening real time. So with all of the algorithms and different steps and different levels of compliancy that a prescription drug has to meet, it's all happening at the pharmacy when that pharmacist or pharmacy tech hits the process button. So it's important, if there ever is any questions, to, go ahead, ask the pharmacist, ask the pharmacy tech, or call PROACT so that we can kind of pause, take a step back, and get you your answers.
Okay, guess we'll talk some more about provider networks and cost. Go right into that. As everyone's aware, there is different places to seek services, and that is hospital. And I always kind of go back to our Blue Cross and Blue Shield symbols. When you start talking about where the benefit falls in your specific plan, if you think of our hospital symbol called MASH, anything being billed by the hospital comes in and processes under the hospital side of your policy. In some cases, there's a copay. In some cases, anything being billed by a participating hospital is covered in full benefit. The next is our Blue Shield sign. And I always think of the shield in all our Avengers when I come to our superheroes, but that is our provider network. As Steve mentioned, we do have a very extensive provider network. We have all the hospitals within our 31 counties, but when you talk about the Blue Shield side, that could be some copays or deductibles that may come into play, or paid in full on some of the policies. So where the services is coming into our system and how it's categorized. And then last but not least, you'll see what's called a major medical, now under the new Classic Blue, because as Steve spoke about, some of the older products that we've had to replace over the years, where you had $1 million lifetime max on the Master Medical, we now call it Classic Blue, and that's major medical is now called enhanced. So it's an enhanced benefit where you have deductible and co-insurance. And that was strategically done when we had to replace that product. With that, that's where your cost sharing is at. And then also prescription drugs.
Yep. And then for the prescription drug portion of the benefit, you can utilize it in a variety of service centers, such as your retail drugstore, your mail order facility, or any specialty drug pharmacy that is approved to dispense specialty drugs. The benefits, based on whatever benefit plan option a patient is enrolled in, could be different depending on what arena is used for that prescription.
And just to make sure everyone's aware, with arenas and the care that you can seek, we actually have RFP out for what's called telemedicine. This is something that's fairly new. You may have heard of it. It's a big buzzword that's happening. And this is where you're able to see a doctor, view a doctor over a computer or a phone, and talk about your symptoms, and if you need care or if you need a prescription, you're able to get that. So it is something that you're seeing technology change the way the delivery of healthcare is happening. This should be pretty much rolled out the first quarter of 2016 as we crawl, walk, run towards this new delivery system. It's not mandated that you use it. It's just another avenue that our members now will have in the first quarter of 2016. Yes.
And if you have that, what will the sort of cost sharing
It would follow like a office visit. Okay. So, and it's not for every situation, you know, and it's not for every generation. I see younger kids Skyping with a doctor and feeling completely confident, and I don't want to go sit in an office. And I see other people saying, no, I'm only going to my physician that I know. So yeah, it's going to be a change in the delivery, but it's new technology, again, coming into play in the delivery of the healthcare system.
Beth, when you say, it's me, when you say we, I know you mean Excelis. To what degree are you addressing Excelis as the consortium's administrator or Excelis as the commercial provider?
It's going to be available to all of our members. So members that carry a Blue Cross card, and that is the consortium.
It would automatically be available, or the consortium would have to buy that plan or that service?
No, it's part of the policies.
It's a tool, a no-charge tool as part of our plan.
Correct.
I think I get it.
Well, it's actually just, if you think about it, another place of treatment that you can get care from. It's the same care, but it's an open delivery system. It's opening another avenue.
And you think the costs are comparable? Is that the idea?
As I said, we're going to crawl, walk,
we'll
run.
wait and see. Yeah.
Because we need to make sure that we have a vendor that we're confident with their abilities and that they're delivering the standard that we set. So yeah, it's going to be rolled out slowly, I think. But it is something that's being talked about.
So my understanding is that a particular medical group would be providing it as opposed to your own primary physician?
What it is, it would simply be an additional place to seek care. So,
Sort of like instead of going to urgent care, you'd use this?
correct.
Okay.
Right. Any other questions on that? We'll keep you posted on that. So,
I think the cost would be less.
well,
If they don't have to buy a scale to weigh me when I go in.
yeah, well, and that's a very good point. You start to talk about places of care and the cost of treatment. Obviously, an emergency room is more costly than the urgent care center. A clinic walk-in is less expensive. An office visit is the most cost-efficient care. See, you know, when you start talking the scale of care and the cost, so you want to make sure the care in the place of treatment is appropriate. And just looking at the slide here, you have a slew of places to seek treatment. This is just another place to seek treatment. In outpatient emergency, there's urgent care centers, there's the 5-star clinic walk-ins. It's finding the appropriate care for what you need. Obviously, we want to make sure that we're not paying emergency room visits for simple sinus headache. Obviously, we want people to seek their doctors, their primary care. However, it's also supply and demand, making sure that there's the right amount of primary care physicians within the network to be able to handle the care. Provider networks, let's see where I'm at here. As Steve indicated, we do have a very strong and robust provider network. We have all of the hospitals, 100% of the hospitals within our 31 counties. We have about 98% of our providers within our 31 counties. We also extend that out to our Blue Card program. That's our national program that allows you to seek services that are in-network by utilizing a doctor who's participating with another Blue Cross and Blue Shield plan.
And then for the PROACT network, the same kind of deal. We are national. We do have over 95% of all of the country's pharmacies in our network. We are always working to negotiate the best rates. Prescription drug plan rates, or the amount that we reimburse each individual pharmacy, have to do with the chain that the pharmacy is a part of, or for the privately held pharmacies, often they come together and join their own networks. So it's done on either a chain basis or a individual network basis.
Did you want to speak to this?
Sure. Well, we essentially looked at this before, and we're just trying to drive home the point that we're all working around a benefit plan, not only the patient who is receiving the services, but the provider that's providing the services, and then finally the medical TPAs and the PBMs that are working. We're all operating off the benefit plan that we've been talking about all day long today.
I know this is your favorite image, Don, but I think I'd like to see a little leg in the background in the shadow that's the employer who helps design the plan that's offered to you and also intercedes on your behalf with the administrator. Employer counts. It's a four-legged thing.
It's a visual.
Maybe use a horse next time.
Yeah.
Yeah. In and out of network. We spoke about the in and out of network. Obviously, staying in network is the most bang for your buck. And what I mean by that is lower out-of-pocket expenses. And we continuously review our networks to make sure that we have adequate networks. And we continually work with our providers on reimbursements that ultimately affect all of our members. And out of network, as we know, is not participating with Blue Cross Blue Shield, and that would allow us only to pay up to our allowances. And as Steve indicated, any allowances that are paid out of pocket, the difference between allowance and the cost of the care does not go towards your out of pocket. So obviously, utilizing the provider network is to your advantage. Claim administrator, that's us, Blue Cross Blue Shield. We do a variety of services. We handle your billing membership. We put out ID cards. We have our customer care unit. We also adjudicate your claims on an ongoing basis. We negotiate discounts, which is a complex, ongoing negotiations that our provider unit works diligently with hospitals and providers. We handle medical case management, which is very important as we get into some of the complex cases. At the board meeting, we had Dr. McCall come through and review the utilization. The utilization report is about the claims that had happened all of 2014. And just getting the medical director's information and input on some of the high dollar cases is very important to understand where the dollars the consortium is paying and what's going on with those cases. We also handle an entire department that handles fraud and abuse. That is checking on providers, our members, and hospitals to make sure claims are processing in accordance with benefits. This is just a visual of our participating providers. As you can see, this is our 31 counties. We have, as I indicated, 100% of the hospitals. That's 80 hospitals over 31 counties. And just the Excelis network provider alone is over 28,000. So out-of-area medical care, when you seek care out of area, you still have access to Blue Cross and Blue Shield. And this is really important, I think, for when you're on vacation. If you're retired from the county, the city, and you still have your plan intact, you want to make sure if you're in Florida that you have access to care. So it is available through our Blue Card program. If you're traveling or have a college student that's out of the area, out of the 31 counties, they can go online. They can see who is participating by putting in their zip code, pulling up the network, going to a participating provider. Simply by showing your identification card at the provider or hospital, they bill the local Blue Cross. Your 3-letter prefix drives the claim directly into our system. I talked about electronic billing and claim paying. That claim with all the code information, who you are, your identification number, your date of birth, what type of service you had, all goes through our system. We reimburse the local Blue Cross, and you simply pay any out-of-pocket that you have, deductible, co-insurance, co-pay, at the time of service. So just like you're here in Ithaca receiving services, you have access outside. I am very happy to report, this was just reported on the utilization report that was reviewed by the subcommittee in May and also the board most recently, that you actually had 98% of the members utilizing participating providers, which is great because when you talk about our savings, you're looking at $18 million in savings over claims. That is huge money, and that's simply by using the plan. Your members are automatically making that decision to use a participating provider.
Let me be sure I understand that. Estimated provider savings, that's a result of your negotiated agreements with the providers. Correct. So it's a savings to the plan at maybe perhaps the expense of the provider.
Well, yes, and as I said, those negotiations are very complex.
I'm sure.
It's also supply and demand. We do have a large share of the market, which helps us when we go in and we negotiate tough contracts for lower reimbursement. With that, we're also paying our providers on a daily basis, so we are a cash flow into their establishments.
I think you said you have about 98% of the providers in the region. So the guy that's not willing to accept this negotiated payment, because maybe he doesn't have the scale, I don't know, is perhaps, I don't know how to do reverse percentages, but if it's a 42% saving, it's possible that the person out of network is actually charging 100% more. Is that?
They could. I know there are chiropractors that choose not to accept our lower reimbursement because they feel that someone's going to come into their establishment regardless if they're participating or non-participating. So there is that. There's also when a provider actually becomes participating, they actually have to submit a form. It's not, oh, I'm a provider, I'm part of this network, I want to be in the Blue Cross Excelis network. They have to submit an entire form. They have to go through the regulations. There's a committee that determines what's the penetration? Do we need that specific type of specialty in that area? Are we already saturated within that existing area? So
Interesting, yeah.
we're not going to accept more doctors in that specialty. They go back and they research, making sure that all of their certificates and their clearances is all accepted. So there's a lot that goes into just saying, I'm a participating provider. And they also have to adhere to our billing rules and our regulations and how we interact with our membership.
Question, do you basically figure out that we saved $18 million by their list price versus the negotiated price is how you come up with that?
Correct.
Okay.
Minus any deductibles and coinsurance.
Similar to Excelis ProAct, which is a subsidiary of Kinney Drug Stores, we are also an administrator. However, we are a prescription plan administrator, meaning we are processing the claims, we are issuing ID cards, we are reviewing prescription drug cases, very similar to Excelis. We do work with Excelis to make sure that, you know, if we have information and there's a medical piece involved, that our information coincides. We are negotiating our own pharmacy discounts. We do have our own type of case management for high-dollar prescription drug cases happening all the time. And we do offer mail order and specialty pharmacies, not only processing the claims and the services, but we actually own our mail order pharmacy and our specialty drug pharmacy right here in New York State. I already high-level mentioned our network, that it is national. It does include over 67,000 chains. A major difference when working with prescription drug networks versus medical networks is for prescription, there is only in-network. So your benefit for a prescription copay is only available at an in-network pharmacy. In the prescription drug plan world, there is not an out-of-network pharmacy available, because if a pharmacy does not participate with our network, they will not process the claim. So for our members, if they do obtain a prescription at an out-of-network pharmacy, they have to contact ProAct and submit a reimbursement form so that their claim can be manually processed. I'll start. I guess I mentioned before, working hand in hand with Excelis for the consortium on a regular basis. We are always looking for the best way to provide our members with an unparalleled standard of care, providing them with the best provider access, the best, prescription drug access, making sure that we're on top of their cases. Sometimes, the best course of treatment, maybe it's not the most expensive course of treatment. Maybe it is actually a less expensive course of treatment. An example would be a prescription drug that could be more effective to an individual member's case, and we are regularly reviewing alternatives in the market.
Good point,
Yeah.
Ashley. I'm just going to piggyback.
Sure.
It is a very important mix when we talk about cost of care, provider access, and how we negotiate with our providers, but also when we look at the plan design as we roll that all into the consortium. Lots of decisions.
Okay, this is the sprint to the end. So the last slide we saw just ahead of this was a balance, which was a balancing cost versus provider access, which is actually another code word for quality of care. But another factor for the consortium is, in health insurance, is the claim activity, and whether it's the type of activity claim or the amount. And we know that healthy persons lower claims costs. So creating a culture of healthy patients ensures that members will have more energy and ability to do the things they want to do for longer in their lives. So this is the vision that the Own Your Own Health Committee that Mac chairs developed for wellness within the consortium, and the board of directors has accepted this as well. A community that values and practices preventive health care to promote health and prevent disease.
I love that word cloud. Did you notice that napping was one of the words in the word cloud? Right there at the bottom.
That's important.
But hopefully, as I've been looking around, so far we haven't been taking advantage of that. But we do have healthy food, so that's good. So the wellness vision speaks to, for the consortium, facilitating behaviors and creating and maintaining members' health. So that's really what the consortium will be looking at as we move forward. The wellness program that the Own Your Own Health Committee has developed is actually made up of some directors from the consortium, benefit clerks, labor has positions on this committee, as well as healthcare professionals. So this slide are the focus points of the Wellness Committee. Healthy patients are happy patients. Many diseases are preventable, and early diagnosis like glucose, blood pressure, cholesterol, and body mass index helps people know that even though they seem to be feeling fine right now, there's something going on inside, and catching that early can prevent them from having major expenses and discomfort for years to come. And becoming aware of your numbers and making lifestyle choices to lower your risk will keep you out of the hospital and with your family. So lowering your costs of care and lowering the Health Consortium's share of cost for your care as well. And so it's important for everyone to be getting their annual physical and getting these numbers checked. As we do this for our cars, we can do it for ourselves. So we're actually at a little bit of a critical juncture here with wellness and the Health Consortium benefit plans, because the Affordable Care Act requires metal level plans, which we currently have the platinum and bronze plan now within our mix, to have a wellness component. And that wellness component has not been identified at this point in time, but needs to be identified in the very near future. So that's an activity that the Wellness Own Your Own Health Committee is working on. They welcome your thoughts and ideas and actually your participation. They meet on the third Wednesday of each month at 1:30. And there's a very exciting conversation, as Mac alluded to in the last board meeting as well. I'll also make you aware that as municipalities are rolling out worksite wellness programs, that there's a coalition being created within the county for worksite wellness coalition. And this is an opportunity for you to gain new ideas and try ideas out on people that have actually used those in the past. We have some pretty heavy hitters in the county, like the hospital and Cornell and Ithaca College and Tompkins County, as well as some pretty small municipalities and players as well. So it's a very exciting group to support the wellness program. So with that, we're just getting to the summation and questions. So are there any questions that are begging to be answered? Then I will just close by saying that this, both the PowerPoint and the audiovisual will be made available at the website in a few days. So if you want to share this with other people who were not able to attend. And I hope that this was very informative for you, and it's actually very germane, as I mentioned, because with the actuarial value calculation, we will be looking at our metal level plans annually, and there'll be a lot more activity by the board and by its committees to keep us on the straight and narrow. And with that, there are healthy snacks on the table, and I know that Beth and Ashley don't want to eat all those themselves, so they won't look so healthy, and they do. So please grab some on your way out, and thank you so much. You're welcome.